And the first thing we were going to do is go over those questions. Let me see if I can pull them up real quick. And yeah, Gupta, Dr. Gupta, I will actually can get you some stuff. I'm actually Kratom. There's the FDA just had a bunch of deaths that were done. People think it's the thing. Tonight, I will get some information and give to you with regard to the Kratom. And I do have a colleague at University of Florida who is looking at components of that. They're still in the very early stages, but I actually have some of that literature pretty handy. And so what I'll do is I'll sort of pull it up tonight and give you guys a summary of it first thing in the morning. So if you'll just remind me at the end of today to do that, I will be glad to do it because I'm getting those questions quite a bit. And that you're right, there is a lot of conflicting information with regard to this out there. I don't know if I told you guys this or not, but I had an interview, a local paper here. Had interviewed me about cannabidiol oil, and mainly because one of the things that was coming up was the FDA withdrew or sent letters out to some of the manufacturers saying that they could not advertise like they did. And one of the shops here, they interviewed her, the manager in charge. Now, this guy has no medical training, and he was telling the person that interviewed that basically, depending on what condition you had, you would pick which dose. And as I told the girl, I said, so you have somebody that does not really know anything about you medically, but is going to be prescribing doses. And that was the one thing, that sort of an epiphany that came to her from a standpoint of that is an interesting thing. I hadn't thought about that. But it turns out that the company that she interviewed, was the same company. I mean, they were getting their CBD from the company that the FDA had sent the withdrawal back out of there. So it was sort of an interesting scenario. We're getting a lot of misinformation out about Kratom, a lot of misinformation out about CBD oil and so forth. It is one of those things that's somewhat disturbing with regard to the misinformation that's out there. Aiden, is there any chance you can put those 4 quizzes up and let me just do that?
Doctor, you're saying to run the poll from the morning again?
Yeah, could you just put the thing up and I could just read off of there, and that way I could.
Okay, maybe I can copy and paste it into the chat. Would that work?
Yeah, that'll work. That'll be fine.
Okay.
Danielle, I've got some stuff about the CBD too. So what I'll try to do, let me do this, is I'll make a comment about Kratom probably tomorrow morning when we start. I'll just sort of cover that. And let me see if I can pull up some of these articles about CBD oil and Kratom, and maybe I can send them to Aiden and Marissa, and they could just put a folder on Moodle for you, for everybody. So that would just be a reference for you guys. So I'll pull what I have and get that up. And so we'll just have it so you can have it. So that'll work. And then if you guys, during the year or later on after this course, if something comes up about either one of those with a specific thing, then let me know and we'll go from there. Thanks, Aiden. That works out perfectly. So let me go through these on the chat board here. So your first question is, which of the following binds irreversibly to cyclooxygenase? And that's the correct answer, is aspirin. All of them inhibit cyclooxygenase, but only aspirin binds to it irreversibly. Question 2, Reye's syndrome can occur with, and the correct answer is aspirin. That's one of the main reasons why they quit using aspirin in children. And again, Reye's syndrome basically occurs primarily only in kids. I'm not aware of any specific instance where an adult has got it due to taking aspirin. One of the things that brings up about some of the issues about pediatric, drugs used in pediatrics, is that Reye's syndrome is always used, where here's an adverse event that occurs only in kids and doesn't occur in adults. So, that's one of the things they question about just simply lowering the dose and using drugs that were approved in adults but never looked at in kids. 3, hepatotoxicity, a major concern, with the following. Okay, so this question could have been a little tricky, but the biggest thing is the major concern is with acetaminophen. Ibuprofen and naproxen both can have some liver toxicity, but the big concern is more of a problem with acetaminophen. And then, let's see. The ibuprofen is not, Reye syndrome has not, if there has been a case, it has not been specific, but the Reye syndrome only happens, is considered primarily to happen with aspirin, so not with ibuprofen. Okay, toxicity of NSAIDs includes renal failure. We sort of covered this right before we left. Severe skin rashes, true. Gastric bleeds, true. All of the above. So the correct answer is all of the above. There was, Kiara, there was some studies looked to see if specifically there was a study done called BUFFS, B-U-F-F-S, that McNeil ran to see at the request of the FDA. It included like 84,000 kids, and they were given Tylenol, they were given ibuprofen, and one of the things was to look for Reye syndrome, and they did not pick up any cases of Reye. So I've never seen a case of Reye associated with ibuprofen. If there is one, it's a very, very rare one. Okay. All right, so let's go to the slides and pick back up where we left off, and we should get through the opioids today. And I'm forgetting what the next slide set is, but we'll get through this. I think we've got the hormones will start this afternoon. I think we've got hormones, sex hormones, and then we've got L-DOPA, and then antibiotics. Okay. All right, so tolerance is one of the big things, and pretty much tolerance will occur with all of the opioids. Sorry about that. That's one of the things that we recognize, that people taking opioids, that they will develop tolerance. We see a downregulation of the receptor, and basically what we're going to see is the loss of effectiveness with repeated administration. Now, one of the questions that I always get is, how long does it take tolerance to develop? We see generally that first of all, it can vary between individuals. But the other thing that we see is that tolerance with some of the drugs may develop in 2 to 3 weeks. So that is tolerance can develop pretty quickly. Tolerance is dynamic. So remember when we talked about this first week of pharmacology. So if they're taking it every day, then basically the tolerance will develop and it'll take more and more. If they are not taking it every day, then the tolerance will go down. So one of the things that we have is, I get this call all the time about DUI cases. One of the things that we have, first thing I ask them is, do they have a prescription? And a lot of times they say yes. And next question I ask them, are they taking it on a regular basis? So when someone is basically, if they're going to take it every now and then you're not going to develop tolerance. So sometimes we have individuals that take it maybe once a week or a couple of times a week. Like, for example, they don't take it, they've got a medication, let's say they've hurt their back. And so during the regular part of the week, we see that they're really not taking it. But let's say Saturday they go out in the yard and work, and Saturday night they're really hurting, so they take it. Sunday morning they wake up, they're sore and hurt, and they take it. And I do see a lot of people that's like, well, I don't like to take it when I'm working, so they don't take it during the week, or they won't take it during the work day, and they may take a dose at night every now and then. So when you have that type of situation, typically you're not going to see tolerance developing. Okay. Now, as we went through with morphine, this holds true for most other, is there are certain conditions that they do develop tolerance to. So, for example, they will develop tolerance to respiratory depression. People that are taking these opioids, they can take much higher concentrations, much higher dosages than someone who's not, and will not experience the respiratory depression. However, even people with tolerance can eventually take enough to get respiratory depression. They get tolerance to the analgesic effect, so they need more to get the pain relief. One of the things we do get into is sort of this, that when they're taking a lot of narcotics, the receptors downregulate. So one of the things is they actually develop hyperalgesia, which means the pain comes back and it's more intense. So that prompts them to take more. And so it's like this cycle that occurs. The tolerance to the euphoria occurs. That's one of the things that when people are abusing the drug is they require larger amounts. This is one of the things that we get where that individuals a lot of times start diverting drugs if they're healthcare professionals. I've had in situations where I had a student that got addicted and was going through the sharp box at the hospital to try to find Demerol syringes and some other ones. So I found we've had nurses that basically will try to divert it. So one of the things they'll do is they'll maybe pull up a syringe. They'll go get it out of the Pixel machine, pull up a syringe. Then they will, sometimes they take that syringe, stick it in another coat pocket, and then pull up a syringe of saline and give the patient saline. Sometimes they may use part of that syringe. So they may shoot up or take half of it and dilute it out with the rest of it up to with saline. So, and part of the reason is they develop tolerance that occurs. The two things, as I mentioned earlier before lunch, that seems to be resistant to tolerance is meiosis, which is the pinpoint pupils, and constipation. Even long-term addicts will still show the pinpoint pupils. One of the reasons why they will wear sunglasses, some of the aspects is with the sunglasses is that it's to hide the pinpoint pupils, and also they will get constipated. Now, if you look at what happens with somebody that is basically coming off of it or withdrawing, let's see, make sure that's the right side. Yeah. So a lot of times what happens is when they're addicted to it, and Dr. Norton will go into this a lot more detail, but just to give you an idea, is after the drug wears off, these are people that have become addicted to it. They have a high tolerance. One of the things that'll happen is they'll start getting real anxious. They'll start having some drug cravings. So they'll start doing a lot of drug-seeking behavior. That occurs up to about the first 8 hours. Between 8 to 24 hours, still a lot of anxiety, can't sleep, GI disturbances. They can have diarrhea. They can have several other things. Pretty commonly we see runny noses, rhinorrhea. Now that the drug is wearing off, they don't have meiosis. They go to mydriasis, so the pupils become dilated, and they break out into cold sweats. That's the diaphoresis. And then even up to 3 days after this, they will have heart rates racing, nausea and vomiting can occur, the blood pressure goes up, they get diarrhea. Some of them may run a low-grade fever. Some get chills, tremors. Bad cases, they may go into seizures. A lot of times muscle spasms, which are very painful. These are some things that typically occur with withdrawal. And this is, although this is under morphine, this occurs for most of the other ones. So it's one of those things where that all the opioid, there's the degree and the time frame will vary a little bit between the opioids, but the general pattern of withdrawal is what we see is this. Now let's hit a couple of the other a few of the other opioids. So meperidine, it's a synthetic opioid. We primarily use it acutely since it has to be given IV. We're not going to see this for chronic pain, but we see meperidine used quite a bit in the hospital. Um, one instance in which we do see it is like kidney stones. Gives pretty good relief. Its main actions are going to be on the mu receptors. It can cause respiratory depression, like most opioids can. This one is sort of interesting because this is the one drug. This is one of the few opioids that basically what's happening is it causes mydriasis, and that's because it has an atropine-like action. So we do see some mydriasis that can occur with this versus pupillary constriction. Primarily, we use this severe pain. We don't use this one for cough or diarrhea. I mean, basically, we'd have to give it IV. And a lot of times we use this in obstetrics because compared to some of the others, it doesn't have as great of effect as we see with the other opioids on the uterus. Adverse effects is pretty much we can see this drug, we can see some anxiety, tremors, muscle twitches. We can sometimes see convulsions, but they're rare. And when they do occur, the reason typically is because that normeperidine, which is a metabolite and is toxic, can actually accumulate. As I mentioned before, it has an atropine-like action, so that's really an anti-muscarinic action. That's why we get the mydriasis, the dilated pupils, but a lot of times they'll complain of dry mouth and blurred vision. So meperidine is one of those drugs that you have to be careful about. And one other thing I want to mention about meperidine is that it is one that can interact with the serotonergic. It actually has, most of these opioids have a black box warning. Many of them do, about addiction, abuse, and medication errors, that be careful about that you dispense the right thing. They also talk about respiratory depression and so forth. But one of the things with meperidine is that 3A4 inhibitors can increase the concentration, and that can be potentially fatal with regard to those type of things. So there is some drug interactions that can occur with 3A4 inhibitor things. So it's but it's a pretty potent drug, and so you have to be very careful with regard to that. It has weak serotonergic actions. So there have been some potential incidents of serotonin syndrome when used with other serotonergic agents. That's the thing I was trying to remember. Now, let's move to another drug, methadone. As I said before lunch, this drug is most commonly associated with people that are going through detoxing. So methadone, basically, when given orally in a low dosage range, what methadone does is basically at low doses, it will occupy the mu receptor, but it will prevent withdrawal. And at the same time, it will not produce a euphoria. Now, if you use high doses or you shoot it up, crush it up and shoot it up if it's tablet, you can get euphoria. And so with methadone clinics, the idea here was that you would take and give the person methadone, so that would keep them from going through withdrawal, but it would also keep them from experiencing the euphoria. And then what you do is you taper the methadone down. Prior to its use like that, methadone basically what you saw it used for was a pain medication, okay? It's a synthetic, it's orally effective. It actually is very good. I mean, it's equal to potency in morphine in many ways, binds to the mu receptor. So it's a good analgesic. It's absorbed pretty well. It's actually absorbed better than morphine, and it will produce all of all the same side effects. It can produce meiosis, respiratory depression, constipation, all those type of things there. So methadone as an analgesic works pretty good. The downside of methadone as an analgesic is it has a variable half-life. When I say variable, it's not that each person, it varies in the individual, it varies between individuals. So the half-life of methadone can be, I think, up to 58 hours. So if you look at a half-life at 58 hours, that means that if you are not careful, that the person can easily overdose with regard to this. Yeah, here it is. I look up Hippocrates just to make sure. So the half-life is, depending on the individual, is anywhere from 8 to 59 hours. So, you know, if you're treating someone, this is what we run into sometimes, is someone was on oxycodone or OxyContin, and the doctor is afraid about them getting addicted. And back when oxycodone and OxyContin was a real big issue that was showing up, you know, about people abusing it, some docs changed from OxyContin to methadone. Well, the problem was they were dosing like they would with a regular opiate. And like, for example, if they're dosing and the person's got a 59-hour half-life, it doesn't take but a few days, you know, a few doses for that person can get a lot of accumulation. So that's the concern with it. You have to be very careful with it, okay? When they treated opioid abuse, as I told you before, is basically we see that what we do is we put them on methadone in lieu of the drug they're using, whether it's heroin or some other opioid. And then basically by giving it to them, they're not getting the euphoria, but they're not going through withdrawal. And then as we taper them off, any withdrawal that they happen to see basically is going to be less than what you would see with one of the other drugs. So, and again, the big thing is we're putting them on a drug where the withdrawal is not going to be as bad. Now, this drug here is been in the news a lot. Fentanyl is probably one of the most potent opiates that we have. One estimate is that its analgesic potency is about 100-fold greater than that of morphine. Very lipophilic, has very rapid onset, short duration. A lot of times we'll use this during surgeries. And then if somebody is become severe tolerant to some of the other opioids, what we will do is we'll then move them up to fentanyl. And in fact, to use fentanyl chronically, to use the patch, or even there's a lollipop, there's a patch, there's you know, various things available. And we typically are using these in chronic pain patients or cancer patients. And typically, in fact, when you look at the black box for fentanyl, is literally you do not ever give this to an opioid, what we call an opioid naive person. An opioid naive person is someone that has not had an opioid. Okay. So these people that get put on fentanyl chronically basically are going to, in fact, there's a specific dosing schedule or calculation schedule, which tells you, you know, you take and figure out what opioid they've been on, and using that, in the label, it actually will give you how to figure out what dose of fentanyl they should get. This one is, there's been some issues with fentanyl. Let's see, yeah. So they have to have some tolerance to an opioid before we're going to give them fentanyl chronically. One of the big things we've run into fentanyl quite a bit. I saw Arnold's note that it looked like sound is off, and I was like, I've been talking for 15 or 20 minutes with my mic off, but no. So I think it's typically this time of day we start getting a little bit of bandwidth issues that I don't know where that's coming from. But fentanyl is during anesthesia, there are some muscle rigidity that may occur. That's pretty well known. But adverse events pretty much the same as the opioids. Since this is such a potent drug, is typically we're not going to use it to manage acute or post-operative pain. Typically, we're going to try to use some other narcotic or other pain reliever. This is very similar to meperidine, but this one causes meiosis. Where we've run into problems has been sometimes the patch. Doctors have prescribed, started them off too high, seen several cases of that. Typically, there's a dosage calculation in the package insert that tells you if they've been taking this much morphine for this number of weeks, then you should start. So there's a whole calculation to determine what would be the equivalent of fentanyl. But I've seen docs, instead of starting someone off at 25 micrograms, the docs put them up at 75 to 100, and those people have developed respiratory depression. Also, what we found is that with fentanyl on the street, they will chew the patches. These are called chiclets on the street. We have seen there's been some issues with the patches. The FDA has sent warnings out. Personally, I mean, when my daughter was on fentanyl, one of the concerns we had was the patches would fall off. And so one of the big issues that we ran into was that I was always concerned about is that if a patch falls off, the patches you put on every 3 days. Some doctors put on there to put them on every 2 days. But my biggest concern is if a patch falls off and, for example, there's children in the house that may pick it up and eat it, or pets that may get it, that could easily overdose and kill them. The other thing we saw with elderly patients is sometimes they would put multiple patches on because they hurt and one didn't seem to be relieving it, so we've had overdoses. But the other thing we had is people would put patch on, and then let's say they had shoulder surgery, and so people put it on the shoulder. You can put it on the shoulder, the back, the chest. But say someone had shoulder, a lot of people will put it on the same shoulder that's hurt, and then they put a heating pad or a hot water bottle on it. We had some instances of deaths where the increased heat actually made the patch empty it out quicker. So realize that each one of those patches have enough drug in it for 3 days. One of the other things that we're seeing on the streets there are derivatives of fentanyl that are even more potent than fentanyl. And that's something we're seeing showing up in heroin. And one of the problems is it takes an awful lot of naloxone to reverse it. Heroin, I just want to mention a little bit. Mainly, it's not anything you're going to prescribe, but just simply because it's in this class. It's actually a structural modification of morphine. You actually put two acyl groups on it, but that simple modification increases its potency to about threefold over what morphine is. Heroin gets across the blood-brain barrier more rapidly. It's more lipid soluble. When injected, you get a pretty good euphoria, although what we see on the streets now is basically potent enough where people can literally snort it. So we see people injecting it, we see people snorting it. In the body, it actually gets converted to morphine, but it doesn't last as long as morphine. There is no medical use for heroin it's a Schedule 1. And so just mention the heroin. And one of the things with heroin is the killer heroin is basically what we're seeing is it started off where we were seeing heroin, and then we started seeing things like respiratory. We see fentanyl show up in it, and then even carfentanil, which is a tranquilizer used in like elephants. So we do see, Rebecca, you mentioned about how it been. So the thing here is that some people it can be very excitatory with regard to the fentanyl. So different people react. We do see people that do not react well with certain narcotics. A lot of people that don't do morphine well. Others may do fine with one, but not with another one. So that's not an uncommon type thing, and it's always nice to know, especially if you're the anesthesiologist. It's always nice to know if your patient potentially may have a reaction to morphine, to one of these drugs. Okay, so let's move to the moderate agonist. Okay, we got codeine, we have propoxetine, which was actually taken off the market. These bind to the opiate receptor also. Codeine now actually gets converted to morphine. And we find that codeine is it's used as a mild pain reliever. Sometimes it's, you guys remember Tylenol number 3. Tylenol number 3 was Tylenol with codeine in it. But the antitussive, we probably saw it, it's a Schedule 4 or 5, depending on the state. People can even sign for it in many states for cough medicines. And so it's antitussive, which is its anti-cough medications, is actually due to the codeine, but the morphine can contribute to it. The nice thing about using it for a cough suppressant is it doesn't take the same amount to get the antitussive effect as it does to get the analgesic effect. And what we've seen over the years is codeine, now we see a lot of these cough preparations has been replaced by dextromethorphan. That's what you see in most OTC products. Dextromethorphan has no analgesic action and is considered to have a low potential for abuse. But I will tell you that there is a group of individuals, especially young teenagers, which is the most common group, that do a lot of dextromethorphan, and they get it from Robitussin, they get it from several other things. So, yep, it's called grape juice. They call it robotripping. They get quercetins, calling skittling. So there's a whole group, and they're doing large doses of dextromethorphan. Plus, when they're buying it as a cough syrup, you've got dextromethorphan, you've got alcohol, and you've got typically some sort of antihistamine in there. So you got some strong antitussives, and they drink it. So, like I said, it's called grape juice. We see a lot of abuse of that. Again, most of the abuse tends to be in the teenage population. So codeine's actions, we do see analgesia, but it does take a larger dose than what we do it. We do see some sedation, just like with the others. It can produce euphoria in high enough drugs, and it can actually be produce a dry cough, even though it suppresses it. And the other thing is we've seen not only dextromethorphan, but as I said, I've been surprised. I've seen more cough syrups being dispensed around here that have hydrocodone in it. So compared to morphine, it pretty much is, realize it gets converted to morphine, but pretty much it is not as potent as an analgesic. It will not touch the pain that morphine will touch. It is orally effective, actually has a little better oral effectiveness than morphine. Lower potential for abuse. Now, when it says lower potential for abuse, it doesn't mean that it can't be abused. I mean, it may take larger doses. You get less euphoria and dependence on it at the therapeutic doses that we typically use. Now, the mixed agonist and antagonist, what's going to happen here is they stimulate, but they also can block the receptor. So typically what they're going to do is stimulate one receptor, block another one, and that's why we call them a mixed agonist, which means they're stimulating, and an antagonist is when they are blocking it, okay? So a lot of times the effectiveness of these drugs really depend on how much exposure someone has had previously to some other opioids. So in individuals who have not received opioids recently, so in the past several weeks, typically these show an agonist activity, so they're analgesics. In an individual that is opioid dependent, one of the things we may see is, and we have to always be careful, these drugs can potentially precipitate withdrawal. So if the person's not opioid dependent, typically we can get an analgesic effect, but if the person is opioid dependent, then we may precipitate withdrawal, which actually may make the analgesic, may make the pain worse. So pentazocine actually is, it stimulates the kappa receptors, but it is a weak antagonist at the mu receptors as well as the delta receptors. And this one has been used for moderate pain. The idea, one of the reasons it's been used is because it produces less euphoria. So that's one of the reasons. We find that we have to watch the dose very carefully because it can create some real issues with regard to side effects. Checking this. And a lot of times, so pentazocine, basically, it was known the name used to be called Talwin. We used to see a lot of it used there. And what we see now is that we go to the generic. The actual brand isn't made anymore. But the idea was that it would produce less euphoria than morphine. But at high doses, we saw respiratory depression, we saw constipation, blood pressure went up. We actually would see some hallucinations and so forth. One of the biggest problems we worry about this is that this typically it doesn't antagonize the respiratory depression of morphine, so it's not going to block it, but it can precipitate withdrawal if someone's used it. So Talwin has created a little bit of problem, and we don't see it used near as much as what we used to. Buprenorphine, this is probably one of the big ones here that we've seen gain a lot of popularity. Basically, it's a partial agonist on the mu receptor. And so it acts like morphine in a non-opioid patient, but it can precipitate withdrawal symptoms in a morphine user. So we use this one as opiate detoxification. And what we find is that the biggest thing is that it produces less severe, shorter duration of withdrawal symptoms, less than what we had with methadone. We don't have to worry about the variable half-life that we see, but it can produce respiratory depression, nausea, and dizziness. Couple of things you need to be aware of with buprenorphine, and again, Dr. Norton, I think, will go into, he covers opioids and addiction and so forth and detox quite in detail. You will get him in the near future. But one of the big things with buprenorphine is that the individuals that when we start using this, people can, we see people have abused buprenorphine. And one of the things we see that, and I was just talking to a group of physicians this last week, they were concerned that some of their colleagues at other places were were basically using buprenorphine, and the idea is once they came down that the person was cured of his opiate addiction. And they were talking about some of the data suggesting that the need for 2 to 3 trials to go down through it to have success. So there's a lot of issues out there with how buprenorphine is being used. I've seen orthopedics sometimes with where they've had people with chronic pain due to, for example, a bad shoulder or bad knee or hip or something like that, and want to do like a quick 24-hour, give them buprenorphine, get them off the other drugs, and basically let them go. And then we've seen other people that advocate one. But again, you're not really curing the addiction there. Now, one of the things you might want to consider is that with the issue of as much opioid overdose as we get, one thing you may want to consider is having naloxone in your office. You don't even have to be a prescriber now. You can buy it in most states. I think you can buy it over the counter. There's been discussions whether that anytime that an opioid is prescribed, whether that naloxone should be prescribed right along with it. So naloxone is the prototypical agent. Naltrexone is another one, as you mentioned. I think one of you asked me about naltrexone is used for sometimes for alcohol withdrawal, and nalmefene, but probably naloxone and naltrexone are the two biggest ones there. So what these antagonists do is like any other antagonist, they're going to bind to the opioid receptor. And basically what they're going to do is they don't activate the receptor. So they bind and prevent the other drug from getting the opioid. So typically the opioid antagonist, if you give it to a person, a normal individual, no opiate experience or whatever, no opiates on board, it's really not going to have an effect. That's why Narcan is given a lot of times in hospitals. If they even suspect an opioid overdose, they'll hit them with Narcan. And the reason is because if they're wrong and it's not an opioid overdose, it's not a big deal. In patients that are dependent on opioids, what will happen is the antagonist will reverse the effect and can precipitate symptoms of opiate withdrawal. Excuse me. In an overdose, all we're trying to do is we're basically trying to reverse the respiratory depression. But we're not trying to precipitate withdrawal. We're just trying to get them up. But you have to be careful about giving naloxone. Most people would not die if they went through withdrawal. They might feel like they were, but like I said, if somebody came in, they've got respiratory depression, they've got the opiate triad, respiratory depression, pinpoint pupils, and somnolent, they're going to hit them with Narcan really quick. And the idea is they're suspecting, or if someone codes or basically find them unresponsive in the bed, if they've been getting opioids, they're going to hit them with Narcan. So here's naloxone, and basically anybody that went into going into a coma or respiratory depression because of an opioid overdose, naloxone is the way to go. What it does is it will displace the receptor bound to the opioid molecules because these opioids are binding reversibly. So when you give the naloxone, you give a high enough dose of naloxone to bump off the opioid. And it will reverse the effect of all opioid molecules binding to the mu receptor. That includes heroin. Now, one of the problems having some weird stuff going on here. So this actually, I don't know, has anybody ever seen someone revived with Narcan? Just out of curiosity. It's pretty remarkable. Basically, it's almost like turning on a light switch. Here you got somebody that's almost near death, almost near coma, and pretty much you give them the naloxone, and it's like they're sitting up. A lot of times within a few minutes, they're having a conversation with people around them and stuff like that. So, I mean, it really reverses unbelievably. We used to do animal experiments, where we would use narcotics to basically get the dogs or the rats into that rest, almost to they're completely out of it, and then hit them with naloxone, and it's like they just come right up. One of the problems, though, and we always have to be careful about this. One of the concern, and it fits in a concern why I have with people that have naloxone that are have it at their home because their family member or child or something is on an opioid. The thing is that naloxone half-life is only like 60 to 100 minutes. So we have actually had instances where that people have been revived at the hospital from a opioid overdose and released from the hospital and went home and actually died from actually died because the naloxone wore off. Now, what will happen is as the naloxone wears off, the opioids effects start gradually appearing. So they will start getting, somnolent. The respiration will start slowing down and so forth. So one of the things sometimes is to make sure that you've given enough naloxone and they're not dealing with an opiate or have enough opiate on them that would cause it to be prolonged. One of the things, let me get you, Rebecca. Yes, Narcan is naloxone. So Narcan and naloxone are the same thing. Narcan is a trade name. Now, I don't know if you've heard this, but we also see there's what they call naloxone parties or Narcan parties. And what we find is that people will go to where there is close by to a hospital, like the parking lot of the hospital, or close to a fire station where there's EMT, or now they may even just have naloxone themselves. And so what they'll overdose, and then they'll overdose, and then they'll wait a little bit, and then sort of like try to revive themselves. And this near-death experience is like a buzz. So let me see what you've got, Eddie. I lost you here. Yeah, that's probably right. And even with some of these new derivatives of fentanyl, 2 doses may not be enough. I know one of my former students was, I was talking to her about, she worked at a hospital, and we were talking about this in a seminar, and she said that sometimes on Fridays, they notify the ER of how many doses of Narcan they have. So the issue becomes because when you get the people coming in off the street, you don't know if they've overdosed on morphine, heroin, or fentanyl, or see, some of this heroin that's being sold is actually fentanyl. And so she said there have been times when, especially back when the naloxone shortage was occurring, there has been times when they basically have called the ER on Friday nights and said, look, we have X number of doses of Narcan. And if they got a patient came in and had some pretty potent stuff, the question would be is that sometimes they would give it very quickly. And so they would just tell them, we have X number of doses to last us till Monday. And if, once they're gone, we don't have any. So those are some things that are there. But yeah, it's probably in today's world with what's out there is it probably would be good to have a backup on that. So that's what I was talking about with this short duration. We have to be careful because there have been instances where the patient has been treated, recovered, actually been sent home from the hospital, and then found dead, where that they've, basically the naloxone wore off. When you compare naltrexone, it's very similar to naloxone. It has a longer duration of action. That longer duration of action makes you wonder why they don't use it more frequently. But naltrexone, if you give a single dose, it can block the effect of injected heroin for about 48 hours. That's assuming it's, quote, normal heroin. It's not the fentanyl laced or something else laced. We've also seen it used. They've combined it with clonidine. They've used it with buprenorphine for opioid detox. And then we see nalmefene. And to tell you the truth, I can't remember a case or anything recently where nalmefene has been used. It's a parenteral. So it's, by the way, naloxone has a nasal prep now. And, this has a half-life that's longer than naloxone. But I've not seen instances where nalmefene has been used. It's either been naloxone or naltrexone. All right, let's cover tramadol, and then we'll take a break, take our afternoon break. So tramadol is the non-opioid opioid, is the way that a lot of people, in fact, when tramadol came out, it was really touted as being the non-opioid. And what we do know now, and we've had a lot of experience, and we see a lot of tramadol expensed. Tramadol is a centrally acting opioid analgesic. We see it used for moderate to severe pain. Many times I would, moderate pain is, if I had a choice between hydrocodone or tramadol, I would suggest to go pharmacologically with the tramadol to begin with and see if that works. It's one of the, I think that there is less of an issue with it than with some of the other drugs, but there's still, you have to be cautious with it. So it's actually a Schedule 4, where a lot of these other narcotics, hydrocodone, oxycodone, methadone, all of those are Schedule 2. So it actually binds to the mu-opioid receptor. So it is, from that standpoint, acts just like an opioid. But it's not structurally, I don't think it is. I think there's some difference with regard to it compared to some of the others. But it also is a norepinephrine and serotonin reuptake inhibitor. Now, if you think about it, a lot of opioids that we use them. An adjunct we've used is, basically tricyclic antidepressants, and some other drugs, even SSRIs, have been used. So they've shown to sort of improve the response. We do can get you respiratory depression, can get euphoria. That's all due to the action on the mu receptor. And but we do get these noradrenergic and serotonergic actions, and people get addicted to it. And one of the things that's easy to get addicted to is because it's not quite under the scrutiny that we see Schedule 2 drugs. It's a Schedule 4. And we've seen healthcare professionals easily get addicted to that. Rebecca, are you talking about the previous drug with the naltrexone? Does it last longer when injected? Doesn't last longer, but its onset is usually quicker. Sure. So Brady, you asked a question. So the drug schedules, just in general. So if it's a Schedule 1 drug, this means there's a high potential for abuse. Um, and the key point with a Schedule 1 is that it has no medical use, okay? No approved medical use. Schedule 2 is, so they're tiered. Schedule 1 has the highest level for abuse and no medical use. That's the two things. Schedule 2 on down, they all have medical use. So Schedule 2 basically is that it has a high level of abuse. Schedule 3 is the level of abuse and addiction is not believed to be as bad as Schedule 2. Schedule 4, not as bad as Schedule 3, and Schedule 5, not bad as Schedule 4. So to give you an idea, the drugs that are commonly used that are Schedule 2, couple of drugs you got, or one class of drugs you guys will prescribe will be ADHD drugs. So Adderall, methylphenidate, Vyvanse, Provigil, all of those are Schedule 2 drugs. Most of the narcotics are Schedule 2. Morphine, oxycodone, methadone, fentanyl, all of those are Schedule 2. Schedule 3, hydrocodone used to be a Schedule 3. It's been moved up to Schedule 2. And to tell you the truth, I can't remember many of the Schedule 3. Schedule 4s include the benzodiazepines, codeine, and Schedule 5 is, I think, some codeine. I can't remember what else is there. To find out what's listed is you go to the DEA website and you look drug scheduling, and it will list any of the street drugs that are not approved. They'll all be Schedule 1. Now, one of the things that was sort of interesting is when medical marijuana came out, the CBD oil, the drug Epidiolex, which was just approved for seizures, which was the CBD, that was actually originally a Schedule 1 drug, but when it went and came on the market, they moved it to a Schedule 4. Well, I just thought it was funny. It went from a 1 to a 4. That seemed like a big drop. But tramadol is so two things is well, that Eddie, that's the thing that's interesting is medical marijuana is with regard to it is marijuana itself is a Schedule 1, but I think medical marijuana, if it meets the criteria for being medical marijuana, is going to be probably either a Schedule 4 or a Schedule 5. One of the issues that you bring up is going to be I know. That's the one that it just amazes me with this, but it has created a thing. Now, the other thing you got to come into factor with is the DEA from the federal standpoint. There are different states. They can have drugs scheduled differently. So, Eddie, I do not know if that would be on your formulary. That is, to my knowledge, I'm not aware of any discussion that has been made regarding that yet. I know Georgia just passed the medical marijuana law, and but I do not know. Y'all's formulary is going to be a little bit unique, but I don't even know with the new law yet is whether, for example, nurse practitioners can do that. So it's going to be an interesting thing because that is a discussion that's going on. The legal community is having many discussions. I've been involved in a few of those. That the judges do not know exactly how to deal with it. So I know some states in which it's being considered. I was talking to the medical board of the Board of Medical Examiners a few weeks ago, a couple of months ago, I guess it was. I went over there to talk to them about medical marijuana because they're trying to figure out what they're going to do with it. Some people think that if we can, that it has to be extracted from hemp, and then it's okay. What they don't know is that even extracting it from hemp creates a problem because THC can come out of it. So there's a lot of issues about how much THC is going to be allowed, where it's grown from. I mean, even with Georgia just passing it, there is questions of who can grow it and who has to certify it and all this other stuff. So a lot of questions that still need to be answered. Let's see. Let me finish up tramadol here. So one of the things with tramadol is when it first came out, a lot of people were like, oh, well, this is not an opioid, so we don't have to worry about addiction. But we have seen that it does develop physical dependence, we do see some severe withdrawal syndromes. Typically, they're very similar to the opiate withdrawal syndromes, but they can also have some atypical seizure, some withdrawal symptoms can be with seizures. So it's variable with regard to that. And the atypical ones may be associated with the effects on the norepinephrine and serotonin reuptake. Things that you see during withdrawal: mood swings, anxiety, depression, anguish, aggressiveness. A lot of people, which is sort of interesting, describe electric shocks, sensations going through their body. Okay, guys, let's come back at 20 after. This will be our long break. This next section on local anesthetics we're going to cover very quickly, but let's come back at 20 after and we will pick up with that. I'm going to flip through a few slides, so don't let it bother you that the slides are going, but we'll come back at 20 after the hour. That we're really going to cover really comes down to local anesthetics, and I'm not going to ask you a lot about these. I just pretty much want to introduce you to them. So the local anesthetics, as the name implies, basically they are applied locally, and they're pretty much they're going to block nerve conduction. They are primarily acting peripherally. The idea is by applying them locally, they're preventing nerve conduction from the periphery up into the central nervous system. Sometimes we find that these people use these as nerve blocks, but probably the most common use of these is if you've ever had stitches. I always used to ask them whenever I used to get stuff is, why does the local anesthetic that they give you before they stitch you up seems to hurt so bad, sting so bad? Another thing is, if you've ever been to the dentist, then you've gotten a local anesthetic there, probably, most likely. Unless you were like one of the dentists that I went to when I was a child, that he would tell my brother and I, whoever went in first, he would say, well, your brother didn't want a shot. Do you want one? And of course, being, competing with your brother, you always said, no, I can. So we went through a lot of times with having, some fillings put in without local anesthesia. So I just already remembered that. We see a lot of these, many of them in cane. So you see bupivacaine, lidocaine, mepivacaine. Now, some of these drugs like lidocaine are used as an antiarrhythmic drug. Procaine has been used that way. So we see a lot of these local anesthetics used. So what happens is that at your physiological pH, the compounds are charged. And so what happens is, so they have an electrical charge on them, they're ionized. So this ionized form interacts with the sodium channel. There's actually a protein receptor on the sodium channel, and what it does is it basically inhibits its function. So as a result of that, you get the local anesthesia. Most of the anesthetics really just differ pharmacokinetically, okay? What is chosen typically is going to be based upon how quick you want it to kick in and how long. A lot of times it's really duration. So, for example, Procaine, rate of onset is moderate, so it may take a few minutes. Here's a good example. So if you go to the dentist, a lot of times they will take a Q-tip that's swabbed in something, and they will, before they give you your shot, they will basically take that Q-tip, sort of put it against your, on the inside of your jaw. All right, if you look on this chart here, then basically that's tetracaine is what they typically use. So it has a very rapid onset, and it also has a long duration. But they applied it topically, so basically it's going to have a limited amount of they're not going to fill your tooth with just tetracaine typically. So then they give you something that is, they give you the injection. So they give you something with a rapid acting. Bupivacaine has been used. Lidocaine is a slow onset and a moderate. So a lot of times the drugs that they use depends on how long the procedure is and how quick you want the onset. Now, this is something you do need to be aware of, that a lot of times they will add a vasoconstrictor like epinephrine. So the idea here is the vasoconstrictor, when they inject it, the vasoconstrictor constricts the blood vessels so that reduces the amount of blood flow going to that area. So what that does is it basically increases the rate of absorption, decreases the rate of absorption. So the drug sits there. So one of the ways that they prolong action is by giving it a vasoconstrictor, which basically keeps it localized. It also can minimize systemic toxicity, although I have seen instances where that the epinephrine has caused people's heart rate to speed up and stuff like that. Typically, the adverse effects, you may have some individuals that have some reactions to this. It's usually where that we see large doses being given. Systemically, like lidocaine, if you get a high enough concentration, it can get into your into the vascular system or into the brain to cause seizures and cardiovascular collapse. Bupivacaine has been noted to be somewhat cardiotoxic, so we have to be careful about that. And mepivacaine, they don't use it in obstetrics because it can get to the neonate. But the biggest issue that I've seen with this over the years with toxicity has been, I've seen 2 to 3 instances where that a dentist or an oral surgeon has tried to do a lot of work in single visit. And so they gave multiple injections to enable to do a lot of procedures. And I've had actually a law case that came up with that, where the woman developed some toxicity, had some cardiovascular collapse, and basically that was all attributed to, the reality of it was attributed to that they got so much injections that they got systemic absorption. And the only other one that other than a couple of the dental things where they've given a large enough, they used a drug called Marcaine. The only other thing I've seen was I saw where that there was one of these plastic surgeon sets up in the strip malls, and basically what their situation is. So a 23, 24-year-old girl that went in, and they used a lot of local anesthesia coupled with systemic anesthesia, general anesthesia, and told her that she would get a big discount if they allowed her to do everything. So they did tightened her chin up. They did, or sort of a chin lift. They did a breast reconstruction, bilateral breast reconstruction, a tummy tuck, and one other thing. And she died as a result of overdose of those drugs. Those guys got sued pretty heavily, which just amazed me. But when I saw, being an expert in it, and I saw it, there was a contract that says if you allow us to do multiple procedures, it was like 10 to 20% off of each procedure that by doing it. So they actually brought her in, did it as an outpatient. She was under for, they tried to keep the general anesthetics low and tried to use a lot of local anesthetics, and then sent her home with a lot of pain medicine. She died that evening. So that's the local anesthetics. They're basically sodium channel blockers, and typically we're not going to see, lidocaine, when we use it as an antiarrhythmic, it's going to be injected IV, and so that's where we really get that. All right, so that is pretty much an overview of the analgesics. Let's move to, give me just a second to pull up slide set 3. And I've got to remember which one that one was. So slide set 3 should be sex hormones, talking about we're going to talk female sex hormones, and we're going to end up with the male sex hormones. And then tomorrow we're going to finish up with other hormones, and then we're going to do the movement disorders and then the antibiotics. Yeah, so that's it. All right, so we're going to get into, as soon as my slides open up. My computer is being a little bit slow, so please just bear with me for a minute. For some reason, it says it is downloading. Let me see if I can pull it up a different. I gotta see if this one, just make sure. Does this look like the one? I know this is the title slide. Hold on one second. Does this look like the one you guys have? All right, well, I think this is the one. Okay, so if this, because I've moved some slides around on some of these in the past, so if this differs, you guys flag real quickly. So we're going to start with the female sex hormones, and so just as a quick review, because this will go in as we know that the female sex hormones, and these you should have been from your slides back with regard to when we had clinical medicine. So what we do know is that these are, they develop secondary sex characteristics. We use them, probably the number one reason that many of these are used are going to be control of pregnancy and control of the ovulatory menstrual cycle. And we do know that they do modulate several metabolic processes, okay? And again, this is just a review of what I showed you in clinical medicine, even though it's been a while. So what we have here is that we know that in the hypothalamus, we have gonadotropin releasing hormone activates the pituitary gland, anterior pituitary gland, to release gonadotropins. And just keep in mind, both today and tomorrow when we're talking about hormones, remember GnRH is gonadotropins compared to growth hormone, which sometimes is GH. Or GRH, which is growth releasing hormone. So GnRH is gonadotropin. So the hypothalamus normally releases gonadotropin releasing hormone, which stimulates the anterior pituitary to release the gonadotropins, and the gonadotropins are going to be FSH, which is follicle stimulating hormone, and luteinizing hormone, okay, which is LH. All right, the gonadotropins are released into the bloodstream, and then they will stimulate the ovaries to release estrogens, and the estrogens get released into the bloodstream. And so under normal physiological processes, the release of estrogen stimulate breast development. They stimulate increased vascularization of the skin, development of the reproductive organs. And also estrogen will increase deposition of adipose tissue in the breast, thighs, and buttocks in females. Now, at the same time, that estrogen is released, as you can see from here, it serves as a negative feedback, so it will inhibit the gonadotropins and shut them down. So once the body has enough estrogens, then what we find is that it will shut it down. Okay. All right, so I think the first red shows up on slide, I forget what number it is, Jordan. Let's just double check that. I think that's what I looked at. So let's bump ahead to 8 real quick. And we're good. Yeah, okay, good, thanks. All right, so basically the normal reproductive cycle is in the female, as we're gonna see, we went through the LH and FSH being released. But what happens now, let's talk about the reproductive cycle, is when that follicle stimulating hormone gets released, it actually stimulates the follicle to mature. And there's the granulosa cells, which are present, basically will secrete the estrogens. And the estrogens will cause the uterine lining to thicken. So what you're basically doing is it's developing or preparing the uterus for implantation of a fertilized egg. Then what happens is you have luteinizing hormone surge. Remember, we talked about that it needs to be a surge. If it is simply if it's not a spike to release, then basically it has an antagonistic approach. It's just the opposite. But this surge, which is like a spike of luteinizing hormone, actually will stimulate ovulation. So what's happening is the estrogen is stimulating the uterine lining to thicken. Luteinizing hormone causes the release of the egg, so that's ovulation. And then there's in the ovaries, you've got the corpus luteum starts developing. It's secreting estrogen and progesterone, and that sort of helps things go along. The combination causes the uterine lining to thicken, becomes more vascular in anticipation of basically that there's going to be an implantation, and the increased vascularity is necessary because you got a thicker lining and you got more tissue that needs blood supply. And the other thing that happens is when the estrogens and progesterone levels go up, the negative feedback basically inhibits the secretion of FSH and LH, so gonadotropins are inhibited. The corpus luteum starts degenerating. When it degenerates, you don't have any more estrogens or progesterones produced. And as a result of that, basically what's happening is there's evidence that there's no pregnancy. So what happens is that the uterine, when you shut off the progesterones and the estrogens, the blood supply diminishes and the uterine lining disintegrates. It just becomes necrotic and disintegrates and sloughs off. And when that occurs, the sloughing off is when the menses occurs. That's the period in the blood and the tissue that's observed. Now, since the estrogen progesterone levels are shut down or drop, then the anterior pituitary is no longer inhibited, so we repeat that cycle. And we see this graphically here, and what we find is this is based upon the normal cycle, or the quote perfect cycle, what a lot of people sort of refer to it as 28 days. But one of the things that we do realize is that basically that can vary. Some women, 28 days may be their cycle. Another woman may be 30 days. Some women may be 35. Some women may be 25. So different women have different cycles, and that doesn't necessarily mean it's abnormal just because it's not 28 days. Okay, so if you look at this graph here, you see that if you look to the right, you can see what's happening with the uterine lining is as the estrogen and progesterone levels go up, basically what you see is you see the uterine lining getting thicker and you see the vasculature increasing. And then when the levels drop, and you can see to the far hand right there, is when you can see the pink and the green, the estrogen levels and the progesterone levels start dropping. And then what you find there is then shortly thereafter you get the menstrual cycle where that tissue is sloughed away. On the left-hand graph, you notice that there's that peak of LH. You get that big spike of LH that occurs right before ovulation. Now, when we look at hormones, so this is the general cycle. Let's move into these particular hormones from a pharmacological standpoint. So one of the things is, one of the reasons we can't have zero cholesterol, when we talk about cardiovascular disease, this is one reason. Another reason is cholesterol is used for doing a lot of cell membranes and so forth. But what we find is that the precursor to many of the sex hormones, or almost all the sex hormones, is cholesterol. And so you can see the structure. And what you see here is that the steroid structure, which is this ring structure here, is common for all of these steroids. But take a look at this. So we do cholesterol, and we do a few minor changes to get pregnenolone, and that is the precursor to testosterone. Now, so testosterone, this is what the structure of testosterone looks like. Look at estradiol. So the difference between testosterone and estradiol is, you look, it's still got, both of them have the 5-ring structure, okay? Testosterone doesn't have a hydrogen ion here, whereas estradiol does. But testosterone does have a methyl group, which is a CH3. That's what estradiol does not have. But both of them have the CH3 and the hydroxyl group. So the difference between the male and female hormones really comes down to a hydrogen ion and a methyl group, okay? So estradiol can be formed from testosterone. Estradiol can then go on to form estrone, which is another female hormone. And estrone, again, what you're doing here is you're taking estradiol, differs with a hydrogen group. Over here, estrone does not have the hydrogen group. And then estriol, which is another hormone, basically has a hydroxyl group and another hydrogen ion. So very subtle differences in the structure. And when you look here, this is another, I put this slide in here with my students, is DHEA is a hormone that you used to buy over the counter, and people thought of it as the youthful hormone, because we know that DHEA is produced in males, and that it probably peaks when you're in your 20s, and then by the time of 55, DHEA levels have dropped. So one of the things that people have done is they said, well, a lot of the effects of aging must be due to the decrease in DHEA. So people were using DHEA to try to gain their youth. So what you see is, this is sort of an interesting thing, because both males and females used it, even though it was considered more of a male hormone. But notice just that the idea here was that DHEA would be converted to androstenedione, which was actually available over the counter for a while, which I think a couple of the baseball players, major leaguers, used, and Mark McGwire, I think, was one of them. But DHEA gets converted to androstenedione, which actually gets converted to testosterone. Now, in some individuals, what you actually saw, they took DHEA and it went from androstenedione onto estrone, or it went from androstenedione to testosterone to estradiol. So in some individuals that were taking this to increase, theoretically, their testosterone levels, there were some of these individuals that actually developed estrogenic effects. And we saw both in males and females that sometimes that they convert, because the structures are so similar, that in some individuals they may be wanting the androgenic effect, which is the testosterone, but actually develop the estrogenic effect. So just as a point to be aware of there. And I'm not expecting, the red here is not stuff for you to know, it's just to illustrate a point. So when we talk about estrogens, there are 3 natural estrogens, okay? 17-beta estradiol. This is the primary estrogen that's produced by the ovaries, okay? Estriol is produced in the placenta, and estrone is actually a metabolite of 17-beta estradiol, okay? It's also produced by the ovaries and also during postmenopausal phase. Now, one of the problems is, well, when they are produced in the body, what's going to happen is they're going to actually be transported to their tissues by usually a protein. What we find is that the proteins that carry these hormones, these sex hormones, basically they have a high affinity, which means they attach them very quickly, but they can't carry a lot. So it's sort of like if you were going to hug somebody, let's say you're going to move somebody, and what you did is you picked them up and hugged them up and carried them. So you might have a high affinity for them. In other words, you could squeeze them tightly and hang on to them, but you would have a low capacity because you could only carry one at a time. So basically what we find is estrogens get carried by sex hormone binding globulin, and progesterone gets carried by corticosteroid binding globulin. And you've seen this slide before too, but again, just sort of review for you. Here you see that the steroid estrogen is being carried by the carrier protein. It gets released at the tissue. It goes into the cell and gets carried to the nucleus, where it actually induces its effects. So again, what we find is, what do estrogens do? All right, so we're looking at these from a pharmacological, not from a physiological, okay? So although sometimes these overlap. So we see that they can regulate the reproductive tract. They can regulate the pituitary. They can regulate the breast during the ovulatory cycle. One of the things we do with hormones is that we're going to use them pharmacologically to either help regulate or to modify primarily the reproductive tract during the ovulatory cycle. We're not going to use them as much to regulate the pituitary gland or the breast, but we're going to use them more for, actually what we're going to do is to try to trick the body into thinking it's pregnant. Okay. We have to be careful, because one of the things is, we do know some of these estrogens that we do have what we call estrogen responsive tumors. So one of the concerns is, when we use these pharmacologically, we have to be aware of that. If a woman basically has an estrogenic tumor or is an estrogenic responding tumor, then we probably are not going to use these drugs. One of the side effects that we see with estrogens is water and sodium retention. A lot of women that go on birth control pills that contain estrogen, one of the main side effects that they don't care for is that they actually may start feeling bloated. We have to be careful, because that water and sodium retention also in some women may actually raise their blood pressure. So that's so those actions are side effects. So if we look at it therapeutically, what we're looking at is we're going to say regulation of the reproductive tract. That's therapeutics, okay? Toxicity is that we're going to really be concerned about progression of some tumors, increased water and sodium retention, which can cause bloating and also can raise blood pressure. The other thing is that sometimes these will decrease bowel motility, so that some women, this may be, they may like this, some women may not like it, but it can cause constipation. Another thing that's going to happen is estrogen, one of its physiological actions is to increase fat deposition in breasts, the buttocks, and the thighs. This can occur with women on birth control pills. They can not only get bloated, but they may start putting fat on in these particular areas. Although we're not, and sometimes in young women, we don't really use these to initiate breast development. However, one of the uses of these drugs now is when people are changing their sex, is that we can use these estrogens to induce this. So that's another concept that's coming into play. We've seen an acceleration of growth at puberty, and sometimes they can stimulate the closure of epiphysis. That's the bone, ends of the bone. So it can sort of stimulate it can close that. But really what we see, some of these effects here that about increased fat deposition of braids and the breast development, that's becoming an accepted use for these drugs, which I'm not sure that it's approved for that. So it would be an off-label use. We do see that they can stimulate synthesis and secretion of prolactin. So that's one of the things that we see a lot of times physiologically. The estrogen levels get elevated, which can then cause, production or it can actually produce milk and gets the breast to start producing milk. We do see that there is cellular proliferation in the uterine in the absence of progesterone. And one of the things, this last one down here, is one of the reasons that these are used as contraceptives, is that the idea here is that in addition to having their effects on the uterus, the uterine lining, and even with ovulation, one of the things is that many of these estrogens can thicken the vaginal mucosa and sort of thin the cervical mucus, and that can affect sometimes the implantation process. Postmenopausal, one of the things we see is that with the lack of estrogens, we see osteoporosis occurring. So one of the reasons for giving hormone replacement therapy, primarily estrogens, to females postmenopausally is to increase bone mass. The other thing that's found was a benefit is it does decrease LDL formation. So it was believed that the estrogens may actually decrease cardiovascular risk. So these are things that have come into play with the effects of estrogen. With progestins, progesterone is probably the most important natural progestin. And we also have several others, 17 alpha, 20 alpha, 20 beta, hydroxy components. They're weak progesterone agents. So what progesterone does is it basically can, we see their levels normally rise quickly in the luteal phase of the menstrual cycle, and that it works with the estrogens to prepare the uterine lining. And actually, when people are monitoring their ovulation, when we see that increased basal body temperature in the luteal phase, then that's due to the progesterone. So if without the progesterone, we can't maintain the uterine lining. So that's where you get the sloughing there off. But progesterone, one of its big things is to help maintain the lining in pregnancy. So two things it does is, one is it helps, makes changes in the uterine lining to keep it intact and nice and vascularized and so forth. And it also inhibits uterine contraction, because when a woman is not pregnant, then the progesterone levels drop, so the uterine lining deteriorates. And the other thing that happens is, with the deterioration of that lining and the lack of progesterone, then basically the uterus will start contracting. And that's where what's happening is uterus is contracting, and it's basically shedding the uterine remnants. And a lot of the problems associated with the sometimes with the cramping and so forth that occurs during the menstrual cycle, during the menses, a lot of times progesterone is because there's no progesterone or low progesterone. And sometimes by using birth control pills, you can actually keep a little bit of progesterone there, which makes the uterine cramping a little bit less. Progesterones have sort of the opposite effect as estrogens. We don't use a lot of progesterones in many of these preparations because they can increase LDL and HDL, so it can potentially increase cardiovascular risk. And but it does increase the amount of sodium water, so you get rid of the bloating that occurs. So we have to be careful with the doses we use. And probably the biggest thing we've seen is that over the years, the biggest thing that we have seen when birth control pills first came out, we were using much higher dosages of both estrogen and progesterone. We were having more side effects. And so what we basically have done is significantly drop the amount of estrogens and progesterones in these preparations. These have been used for fertility, basically birth control pills. Typically, we call them, they're abbreviated as COCs, which is combination oral contraceptives. And that is a combination of estrogens and progestins. We can see sometimes there's instances when we use only progestin. There are some instances when that occurs. Postcoital, this is the morning after pill, typically is going to contain higher doses of estrogens and progestins. And we can also use these for contragestation. So we've seen several uses of those. Typically, we've seen for hormone replacement, we've seen it in menopause to try to prevent osteoporosis. We have used these drugs when osteoporosis is occurring, even though it may not be associated with menopause. We've used these where an individual has undergone ovarian failure. A big use of these has been when we have dysfunctional uterine bleeding, that the individual is having very heavy blood loss or very painful periods. We refer to that as dysfunctional uterine bleeding, and these drugs can sometimes level out the period so that it's not as unpleasant as it was without the drugs. And we've seen also for some problems that have occurred during the luteal phase. So a lot of uses, but basically the overall uses is to try to regulate the menstrual cycle, either for improving pregnancy or, preventing pregnancy, planning for pregnancy. I can't get the answer to that on Apple. My Siri didn't like what I was saying. I thought Siri was turned off. And apparently everything I just told you, they can't get the answer to it on Apple. So, but we also see them have been used for post-hormonal, postmenopausal, for primarily osteoporosis and cardiovascular. A lot of things there, we don't see it used as much for cardiovascular benefit, which was given the estrogens, but that is recognized as a potential additional benefit. We have used some drugs basically to induce ovulation. We've seen one of the drugs is clomiphene, but there's sometimes by just regulating the period may be all that it takes. And then we have seen these drugs, hormones used for certain cancers. And this includes some breast cancers, some endometrial cancers, and we've seen it in males. We've seen estrogens used for prostate cancer. Another group of therapeutic aspects we'll talk about is endometriosis, which is a significant problem. And some of these therapeutic uses have also included just some diagnostic, trying to determine what's going on. All right, so we have these natural estrogens, and the issue is that a lot of people like to use natural agents. The most potent is estradiol. The biggest problem with using natural estrogens is basically they're not very effective orally. They have a low oral potency. And the reason for that is really twofold, is that they are poorly absorbed. And secondly, once they are absorbed, a large portion of them is going to be metabolized by the liver. So one of the problems is that trying to use the natural estrogens like estradiol, even with estrone or estriol, is that it's very, very difficult because that they do get rapidly inactivated, and they're just, their bioavailability is very poor. Well, one way we got around it is we used what is called conjugated estrogens, okay? So conjugated estrogens, actually, if you've heard of a drug called Premarin, Premarin is actually, the name comes from basically prepared from mare's urine, okay? So actually pregnant mare's urine. So what happens is that you can get estrogen, you can get equilin or estrone. Equilin is found, it says equilin, but the equine is from horses only. It's not found in humans. But what happens is that when the natural estrogens in these pregnant mares is processed through the body, remember about drug metabolism when I told you that one of the things that happens is conjugation, and it makes it more polar? That's what happens. And so what we find is that some estrogens that are in the pregnant mare, basically when they're metabolized, they become water soluble and conjugated. And so they're collected from the pregnant mare. And the thing is that these are water soluble because they're conjugated. They have virtually no estrogenic activity. But you take that conjugated estrogen, and if you take it orally, so they isolate it and put it in a pill. So if a human then takes it, then when it's basically hydrolyzed, that's clipping off that big conjugated molecule. So by using this, it allows it to be absorbed, and it's water soluble, so it gets absorbed into the bloodstream, and then basically when it gets metabolized, it becomes activated. So that's one thing that we've seen, and Premarin is a good example of that. But probably majority of what we see used is synthetics. And what we've done is gone into the lab and we basically altered the structures of these primarily to make them more soluble and still be potent. So primarily the estrogen that's used in most oral contraceptives is ethinyl estradiol. Okay, it's estradiol, but it's been synthetic. It's basically been made in the lab. Another drug that we've seen used is mestranol, which basically what happens with mestranol is that it gets converted to ethinyl estradiol when it goes through the liver. But we've also seen some estrapipate and quinestrol. The nice thing about these synthetics is they're very orally active, and we see these predominantly used as oral contraceptives. The synthetic nature of them, the way that they've been synthesized, allows for them to be very water soluble, so they're absorbed. They are orally, let's just say they're orally active, so they're orally active so you can take them orally. And it's allowed us to really reduce the dosage of estrogen that we need to give, which means by reducing the dosage, we've reduced a lot of the side effects associated with them. So we also see there's some synthetic non-steroidal estrogens. We see diethylstilbestrol, chlorotrinazine, dianostrol. Those are there too. But again, the biggest ones we are going to see are ethinyl estradiol and mestranol. And mestranol actually gets converted to the ethinyl estradiol. Now, progesterones, because sometimes we have estrogen only, sometimes we have progesterone only, and sometimes many of them are combination, which are progesterones and that. So we have all these different progesterones, but probably what we see used most is either levonorgestrel, norgestrel, or norethindrone. These three here are the most common progestins or progesterones that we see used. So what we found is that combination oral contraceptives, COCs, are probably the most effective reversible method. Key point, reversible, okay? Failure rate is less, assuming compliance, is less than 0.7% per 100 women. Typically, we see either the estrogen component is ethinyl estradiol or mestranol. Mestranol is less potent. Why would we use the mestranol? Sometimes being a little less potent, we may not have, you'll find that there's a lot of different preparations out there. And sometimes it's just finding the right preparation that gives the least side effects for the woman. And then we see the progestins, either norethindrone, acetate. Those have all been used in this combination, but many times it's norgestrel or levonorgestrel. Again, by being able to lower the dose has been a big, when these drugs first came out, we had several side effects that were not necessarily pleasant. And now we find that a lot of women can take these. You're familiar, most of the formulations, they're 21 days of a combination, then they have 7 days off. They're usually in a pill pack, and they've got, basically the days when the pill pack is, when they're to allow the bleeding, so withdrawal bleeding, those are usually placebos. Some women don't take those. Some people just ignore those and don't take them, but they've done them. The main reason for it is to help compliance and make sure nobody misses a pill. But again, sometimes if there's some side effects, they may use some other dosing package. And now we have, ones where we have the depots, we have the ones where that you take them in their 90 days, those type of things. All right, let's take our last brief break for the afternoon. I've got 5 after the hour. Let's come back at 10 after the hour, and we're going to go through the oral contraceptives, and then probably in 25 minutes or so we'll break so that you guys can take your questions. Then tomorrow I will answer those questions. So let's take about a 5-minute break, and we'll start back at 10 after the hour. if you think about this negative feedback, so what we're going to do is that basically the idea is going to prevent ovulation. That's the main mechanism with using these as oral contraceptives. So what it's going to do by giving the estrogen and or progestin, it's going to inhibit the secretion, the gonadotropic secretion, so the LH and the FSH, okay? And that's going to it's going to be acting by its actions on the pituitary and the hypothalamic. That's about 90 to 95% of the time. So what's going to happen here is when we give a progestin, that's going to suppress the luteinizing hormone secretion, and therefore it's going to prevent the LH surge. Remember, that has to be a surge or a peak, or a spike, I should say. So if you do that, it prevents ovulation. So without ovulation, you're not releasing an egg, so it can be fertilized. The estrogen component actually suppresses FSH secretion, and that prevents the emergence of a dominant follicle. So that's the main mechanism. Now, in addition to that, the estrogen it basically provides stability to the endometrium. So that's the uterine lining, so that we don't get the irregular shedding and breakthrough bleeding that's minimized. And sometimes we're using these to sometimes actually normalize the period. And the other thing that happens is the estrogen actually will potentiate the effects of the progestins. And probably we think it's because the estrogens will actually increase the amount of the intracellular progestin receptors. So one of the things that will happen is the presence of the estrogen there seems to cause an emergence of more progestin receptors to make it more effective. When you look at progestin, is that basically the progestin combinations that we use will make the endometrium so it's not receptive to the ovum. So the egg, if it's released, then it won't implant or has a hard time to plant. Another thing that progestins do is they thicken the cervical mucus. So when the sperm is trying to swim up the birth canal or try to go through the cervix, what's happening is the mucus is like a thick pit, a mud pit. So it slows down the sperm from moving up there and forms sort of a barrier there. We see there's been some suggestions it may affect the peristalsis of the fallopian tubes. And so basically what you see is that the combination sort of hits several different areas. Most COCs, combination oral contraceptives, they contain what we call pharmacological doses, actually doses higher than what would be produced physiologically. So you may hear this term more frequently as we sometimes talk about physiological doses would be doses that produce concentrations that you would expect to see physiologically, whereas pharmacological doses are usually higher and what we would only achieve if we were using a pharmacological agent. But typically we're using higher than physiological doses of estrogen and progestin. And we tend to have progestin, when we've got both of them, progestin tends to be the predominant hormone there. So what we really see is that we see more of if you look at the endometrium, it tends to be more in a state of what the progestin would produce. So if you sort of summarize them, I mean, we went through all of that, but the bottom line is what they're going to do is they typically prevent pregnancy by inhibiting ovulation. They inhibit the release of the egg. They inhibit the implantation of the egg. And we don't see those peaks of follicle stimulating hormone and luteinizing hormone. So it's almost as if what you're doing is you're making the body think that it's pregnant is what you're doing. Now, one of the big things that always comes up, and you may get this question from some of your patients, is what happens if I miss a pill? Well, typically what we're going to say is if you miss one pill, does it increase your chance of pregnancy? Probably so. Is it a significant increase? Probably not. But 2 or more doses missed during a cycle substantially increases the risk of pregnancy. So we typically will tell people if they've missed 2 or more doses, 2 or more, is we're going to suggest strongly that they use alternative birth control until the next cycle. We also see that there has been, with these drugs, there's been some other benefits. There's been a decrease of incidence of ovarian and endometrial cancers. Now, there are some cancers, reproductive cancers, that are what we call estrogen responsive. And if you have one of those cancers, you don't want to use this. The nice thing about it is the protection against ovarian cancer seems to last for estimates of 10 to 15 years after discontinuing the drug. So if people were on the on birth control pills and they stopped, then basically we still see some protection there. There was one suggestion that there seemed to be a causal link, that there was that if you used oral contraceptive use and endometrial cancer, basically that could lead to cessation of use. So what they were using sequentially was 14 to 16 days of estrogen alone, then 5 to 6 days of estrogen plus progestin, and then 7 days without steroid. You don't need to worry about that. That's, sort of a dosing concept. We also saw some other benefits. A lot of women have fibrocystic disease. With oral contraceptives, we saw a 50% reduction in that. We saw a 10 to 70, depending on which paper you read, a 10 to 70% reduction of acute pelvic inflammatory disease. Now, one of the things with COCs that you have to be aware of is sometimes we find that with PID, which is pretty severe, is sometimes with birth control that you may have someone that is being pretty promiscuous or having multiple sex partners, which could potentially increase the pelvic inflammatory disease. Aiden, did you take attendance poll yet? Thanks, Eddie.
Yeah, I was having online waiting for for
okay.
yours. Thank you.
All right. Now, one of the big things was when oral contraceptives first came out, there was a lot of controversy. There was a lot of issues of morality with regard to that this was going to allow people to, just become sex addicts and things like that. There was all these aspects of that, this was, so there was all these things that came out, and there was a lot of controversies, especially about the side effects. Some of the side effects, the controversies came up because there was a lot of misinformation coming out there. There was a lot of different things that came up. I mean, when I was at Auburn, they had conversations that, that if we offered those at the university pharmacy, at the health center, that all of these co-eds were going to show up with all these, they were going to be sexually active. They were going to develop all these STDs and so forth. But also there was a lot of debate with regard to a lot of side effects, and there was there was no doubt that the combination oral contraceptives were more effective than any other thing. But there was a lot of issues about side effects, some of which, one of the things that we saw was a lot of women put on a lot of weight. They got bloated, a lot of sodium water retention and all this other thing. And so therefore they felt like they didn't look attractive. So there was that. There was all these other concerns. But one of the problems was, when we look back at it from today, is one of the big issues was that we were using much, much higher dosages than what we currently use today. We have drastically dropped the dosages down. We saw a decrease in a drop of dosages, and then we saw another decrease that was there. And in fact, after the first decrease, it would be difficult to try to get an agent or a drug approved at the dosages that they were really released at. The FDA wouldn't even think about releasing or approving those. The other thing is that there was a lot of criticism of that. The early studies actually didn't look at different subgroups of patients, so we didn't have really accurate information. We saw that certain high-risk groups were restricted from trying these, and so we saw that there was concerns about increased cardiovascular risk. There was concerns about increased cancer risk and all this other stuff. So really, the thing with this slide, I just want you to know, is that some of the early stuff when these first came out was really there was a lot of problems with the studies. Okay, so that's one of the big things that we saw. Now, we're going to cover a little bit, a couple more slides, and then this is going to be a good stop point. One of the big issues with combination oral contraceptives is the concern for idiopathic venous thrombosis. What we did see is that this risk of idiopathic. I don't like the term idiopathic because idiopathic sort of like we don't know the cause, but we do know that these oral contraceptives can cause venous thrombosis. So there's anywhere from a 2 to 6-fold increase, greater risk of this with a person that's on an oral contraceptive. That is a significant issue because the venous thrombosis could break off a clot. You could get a pulmonary embolism. So one of the things is we discovered it's dose related. So one of the big things was the fact that we have drastically reduced the dosages has been a big plus. We've reduced the chance of venous thrombosis because we know it's dose related. The other thing we know is that the risk doesn't hang around. That literally there have been studies that have demonstrated that the risk that 1 month after stopping the birth control pill, these combination oral contraceptives, that the risk basically of a venous thrombosis decreases. So that was that was one of those that was one of the things that was there. And pulmonary embolism, and you know, Eddie, that was the thing, is that pulmonary embolism is a big concern. We do have people that develop it, and that was a major concern. Plus, you had more people smoking, especially women. So smoking was another issue that complicated it, okay? Another thing that we saw is we did see blood pressure went up in some individuals. I mean, that typically was more in the estrogen, the ones that had higher estrogen concentrations. What we found is that we could sometimes decrease the estrogen and the risk would, the blood pressure would go down. Typically, you're looking at about a 10 millimeter of mercury increase, and it's reversible. So if that goes up and it's too much of an increase, one of the things that we've done is we just basically take them off the pill and the blood pressure goes down. There was a increased risk of cervical cancer, especially in women that were on the birth control pill for greater than 5 years. These were concerns. We did see that people on there sometimes went on them fairly quickly, and we found that if they were breastfeeding, that the milk production went down. But what we did find out, and this is probably the most important thing, is we do see that they're contraindicated if there's a history of thrombophlebitis. Thrombophlebitis is a inflammation of the veins or the blood vessels, and can set up for a clot. So we do find that is we are screening more carefully. Although they're contraindicated with people with coronary artery cerebrovascular disease, we do see people on that. Obviously, if they think they're pregnant, we don't want them to go on it because it could affect that. And then another thing is that if there's undiagnosed abnormal genital bleeding, what we want to do is we want to make sure that it's not a tumor or some other thing that the estrogens could create a problem. And if they have certain breast cancer, cervical cancer, uterine cancer, or vaginal cancer, those are going to be contraindications because some of those cancers can be estrogenic, which means that what you're going to do is stimulate those cancers. Use them cautiously. One of the big things that we have to be aware of is that there are some drugs that will interfere with oral contraceptives. Our pharmacists are pretty good about letting patients know if they're on an oral contraceptive that if they're taking a drug that may interfere with their effectiveness, not to do that. And as far as smoking goes, this is sort of debate. The data suggests that, and we have had women that have been on birth control pills for longer periods of time. They waited later in life. You know, I've seen people quite a bit. We don't want to have a baby until they're mid 30s or 40s, early 40s. But these are not advised if the person is over 35 years of age and smoking. I still have a concern if the person is smoking in general, but definitely 35 years of age or older, and smoking puts an increased risk, especially of pulmonary embolism. And Jordan, by the way, the concern about all of that was it was probably happening at Georgia too, but I was at Auburn at that time. I just remember all of those discussions that went there. Okay. So there were some women that just could not manage or handle the estrogen side effects. So we have the progestin-only contraceptives. These were not quite as effective, where we had a 0.7 per 100 women years failure rate. For combination, we had 2 to 3. And so a little less effective. We saw a little bit more irregular bleeding, and because we get variable effects on the FSH, because the estrogen primarily, you have to have both of estrogen and progesterone to do that, to suppress both FSH and LH. What we did see was that these drugs they do produce this thick cervical mucus that's sort of scant, which makes it hard for the sperm to get up there, and it does produce some endometrial atrophy, which would mean that it would make it hard for a fetus an egg to implant. These were actually used more for people that had some advanced carcinoma. We've seen these used for people with endometriosis and that sort of thing. But we do see more breakthrough bleeding with progestin only. People have some spotting and breakthrough bleeding. See more mood changes, see more weight gain. Some individuals develop amenorrhea. So the progestin only were not quite as effective and had a few more side effects. But here you're making a benefit risk, because what you're basically doing is the individual can't take the estrogens because of certain side effects. So you're going with the progestins. All right, this will be the last group that I'm gonna cover this slide, and then we're gonna break for you to take the test, and then we will pick back up tomorrow. So one of the big things that happens is what happens with the morning after pill. Okay, so this is a person that is not on a birth control, and basically, one of the things is they have sex, and then they're like, okay, I don't want to get pregnant, so what can I do? This also was used for people that were raped, or if there was incest, or another thing that may happen is if they had using a barrier method such as a condom, or a cervical dam or something like that, or just had unprotected sex. So what the postcoital contraception is that it's large doses of estrogen, either alone or can be given with progestin. The key point is must be given within 72 hours. Okay, that is a key point. After 72 hours, it's pretty much ineffective. Okay. And literally what you're doing is, and you're only doing, you're not taking a huge amount. You're not taking this for multiple days. This is only going to be taken. The idea is to just make the endometrium non-receptive to any implantation. And some people have concerns because from a moral standpoint, it's like, well, that may be a fertilized egg. And now you're, in essence, maybe in some sense, sort of like an abortion, in the sense that if it's fertilized, then they conceive that as as an entity, and it can't implant, then that's what it's there. But we do see people that this is all they use, whenever they may not be very sexually active, and then they are sexually active, and then basically only want to use it. They like that rather than taking others. But again, there is a 72-hour time limit. And also, with the higher doses, you can potentially have some of those side effects. But again, with only taking it for a short period of time, that may not, they can tolerate those. Okay, so this is a good place. We will pick back up on estrogen and finish these slides first thing in the morning. Then we will move to the other hormones and so forth. So we'll finish up the others as we go. So that's all I've got. I'm going to turn you guys over to Aiden. He's going to put up the last 4 questions. And if you guys will just look over what we've covered today, that's sort of your assignment. If you would just look back over, and if there's something you want me to go back over or clarify, let me know, and we'll do that tomorrow. And I'm going to try to look up some stuff and have it for you on kratom and the CBD stuff. Okay. All right. So Aiden has got it up. I'm going to sign out, and then I will see you guys in the morning. I hope you have a pleasant evening. And so good night.